Yo, 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 yo. Hey guys, welcome back to another awesome edition of the Best Practices Show podcast. It is Friday. Happy Friday, everybody. And on Fridays here, our goal is to keep you at the top of your clinical edge with some of the best educators in all of dentistry. And today, we're going to do exactly that with one of my favorite of all time. Dr. Dennis Hartlieb, truly one of the coolest human beings ever. He's been a regular guest for our master classes and podcasts, and he did a recent masterclass called Small Spaces, Big Challenges, the keys to aesthetic and functional success with the congenitally missing lateral incisor. Wow, that's a mouthful. And he's the best to describe what to do. It was so good, I thought, let's share the audio version on the podcast. So here it is. Please listen up. I hope you guys enjoy it, and we'll see you soon. Actually live right by him. I drive by his house every single day. He's been a dear friend of mine for a long time. I knew about him, and then we knew each other, and then through a mutual friend, Bob Margis, he's like, you should really get to know Dennis. Dennis is an amazing human being. And I knew that beforehand, and I'd seen him. I've seen him so many times speak, and I'm like, this guy is brilliant. And so I'd see him at the Seattle Study Club meetings and other meetings, and I had a chance to go to the Restorative Academy many years ago, and so our paths crossed over. And then we got to know each other. So Dennis would come down, we'd have a beer, he would ride his bike, and then I got to hear his story, and I'm like, your story is incredible. Like, I knew you were a great dentist, but I didn't know whose practice you bought, and I want you to tell that story. I'm like, you bought the great you-know-whose practice? He's like, I did. And the training on the job was second to none. Like second to none. Like, I don't know that you could get a better training thing. I also think, Dennis, your story about why you became a dentist and how that all came together is quite remarkable. I also think the story of your friend at the spear course that you went to, and you both came out and she said something to you that is powerful. You're like, oh my gosh, that kind of gives us a little perspective on the journey you've been on. I know you're going to teach us a lot of stuff, but I'm here to tell you guys, this guy's an incredible man with an incredible story. And Dennis, I'm so grateful for my relationship with you and what you do for our community. So take it away, brother.
Yeah. Well, thank you, Kirk. That's super sweet. And thank you very much. Just long story short, today we're going to talk about what do we do with the congenitally missing lateral incisor. In particular, I want to talk about canine substitution because I think it's an underutilized opportunity that we have, but we're going to talk about all that. To sort of address some of the stuff that Kirk was referring to, I've been practicing 37 years now. I'm in the suburbs of Chicago, graduated from the University of Michigan, go blue. We won our first round. Moved to Chicago. I'm from Detroit area. Back in the 80s in Detroit, we had a recession that was just incredible. The auto industry was just completely dead. We had 25% unemployment in the area of Detroit. So if you didn't work for the auto industry directly, then you were absolutely affected because everyone was. So I wanted to move to an area that had a more diverse economy. So I ended up in Chicago, did a residency there, and was practicing. And one of the stories I shared with Kirk is that I had a partner in practice that we knew each other in dental school, Monica. And Monica and I went to the midwinter meeting together. This is back in 92, 93. And we saw Frank Spear present. So Frank was relatively unknown at that point, and he was the Gordon Christensen Award winner at the midwinter meeting that year. And we're like, okay, well, let's check that out. And he just completely blew our minds. So we walked out of the auditorium at the McCormick Place in Chicago. We're out in the hallway, and I turned and look at Monica, and I said, that's what I want to do. I want to do that type of dentistry. And Monica looked at me and said, I'm applying to med school. And literally on Monday morning, she came in and said, I signed up for the MCATs. And she went to med school. She went to Duke for med school, became an internist, and just recently retired. She's up here in Milwaukee, actually, Kirk. She was at Freighted.
Very cool.
So anyhow, so that was like an incredible moment in my life. And then I started following Frank's stuff. I would go out. I took his first live course in his office. I was a total disciple of Frank. I went down to Dawson, did a lot of their stuff. And then I got introduced to a guy named Buddy Mopper. And if you don't know Buddy Mopper, Buddy is one of the pioneers in cosmetic dentistry, but really about composite dentistry. And Buddy was a pediatric dentist that was fixing teeth with composite, back in the 70s and the 80s. He was using the very early silicates and all that type of stuff. And he was really good at it. And Buddy, along with a few others, really started putting composites on the map. Through a roundabout way, I ended up meeting with Buddy. He needed someone who could do the porcelain restorations in the practice to support the composites he was doing. And that's how I got into his practice and learned so much about composites. And now it is absolutely my favorite material. I love drilling down teeth and doing crowns and veneers, but more than anything, I love doing bonding. I think one of the big values in learning to do composite dentistry is that you get to offer patients two options. And so I just had a patient in yesterday she wanted veneers, and we talked about it. I said, look, there's two ways we can do veneers. We have two materials. And in our office, I point back to my cabinets. I say, look, if I wanted to resurface that cabinet, if I wanted to re-veneer them or re-laminate them, I could use pine, I could use oak, I could use some synthetic. I could re-veneer them with any number of materials. In dentistry, we can veneer your teeth with two materials, really. We can do porcelain, which is glass, or we can do composite, which is a resin or a plastic. They both have advantages and they both have disadvantages. And I walk through it really briefly. I say, here's the advantage of porcelain. Its durability and its strength. It's not likely to stain. It's not likely to chip. But the downside with porcelain is I got to take away more of your tooth structure. It's a two-step procedure. You're going to come in, I'm going to do drilling on your teeth. I'm going to take an impression of your teeth. I'm going to make temporaries, and I'm going to send the impression to a laboratory. My laboratory takes about 6 weeks to get the veneers back. During that 6 weeks, your temporaries will come off. Some of them will come off, almost assuredly. You cannot bite into anything. You literally cannot bite into anything for those 6 weeks. You have to cut off everything. If you bite into anything, your temporaries will likely come off. After 6 weeks, you come back. We take off your temporaries, we try on your veneers. If everything looks great, then we glue you together. If they don't, then we take a bunch of photographs, send the veneers back to the lab, see you 4 to 6 weeks later, try them in again. Hopefully we cement them at that time. So I say it's not unusual for a veneer case in my office to go about 3 months, hopefully 6 weeks. Sometimes it's about 3 months. My cat, Chip, here wants to come and say hi. Let me move him away. I say composite, on the other hand, it's all done in one visit. You're in the office, we grind down on your teeth where we need to, but it's much less drilling than if I do porcelain. Almost always. It's going to be less drilling. It's immediate. We can make them look just as good as porcelain. They can be just as shiny as porcelain. Here's the downside with composite. They're more likely to chip. They're more likely to stain. So for my patients, say you got to sort of weigh what makes more sense to you. Are you more concerned about durability? Or are you more concerned about not losing tooth structure or saving money because the composite is going to be less than the porcelain? And I say, what works for you? What's better in your lifestyle? Do you want to have it done in one day, or do you want to have it done over a series of weeks? So it doesn't matter to me. I love doing them, both of them. So whatever you prefer, we can make it happen. And I love giving that option to patients, letting them choose. And those often say, what would you do? And I say, it's not my teeth. It's not my teeth and not my money. So tell me what's more important to you, the durability or sacrificing tooth or spending less money or the time. I mean, I've had people with plenty of money who say, look, I want to be in this chair as little as possible. So if you tell me you can get it done in one visit, I'm in. I'm like, cool, let's do it in bonding. And I have others who say, you know what, I want something that lasts as long as possible. Let's do it in porcelain. That's great.
Yeah, but you're leaving out one piece. You should add
that?
this because you're so, I'm one of the best in the country at composites. You should just say that. Like that would.
I mean, I admit, I said I love doing composites because I have all the control. That for me is such a big issue. I mean, I think most of us in dentistry are control freaks. I mean, that's why we love dentistry because we control everything. The hardest thing for me, literally in my practice, is signing the lab slip to let the case go. My assistant's like, Dr. Hartlieb, you gotta get this case out. It's like, I know, but I know I'm forgetting something on the labs. Like I don't do a lab slip. I do a keynote presentation. I send my keynote presentation with my photographs and my like, okay, this is on my temporaries. I didn't get this very well. We need to improve this. But there's so much stuff that's going in my head. And when I'm doing the bonding, I just can see it and do it. When I'm trying to translate that information to my ceramist, I get really stressed about that. So, but I love doing it. I tell patients my my bias, I love doing bonding because I control it. But what's best for you? That's how I put it. And it takes the pressure off, you know? I mean, that's the worst thing for dentistry. And we have an associate in practice, and I tell him, Greg, the issue in dentistry is managing failures. How are you going to manage the failures?
Yeah.
You
No,
know,
I'm not, I love you so much. So I got to add this. Like, these are things that dentists talk. You also, we did a podcast on this. It's additive. You could reverse, like you can make mistakes and you can slowly build it in a way that it meets and matches expectations. Correct. And then the other thing, can you add this, Dennis? Because we're going to cover a lot of stuff and I'm going to be quiet. The higher the fee, the higher the expectation. Spear used to say that all the time. So this is an important thought process in what you're doing, correct?
for sure. I'm sure every single one of you who's done any indirect cases have had this happen. Patient comes in, you cement the final restorations, they come back and they said, you know what, I like the temporaries better. That ever happen to anybody? It happens all the time. And what happens is you take people from ugly teeth to decent looking temporaries. Now, our temporaries may be a little too bulky, the line angles might not be great, whatever, but there's something about the acrylic or the resin that is softer, and patients get you sort of used to that. And I will tell you, I guarantee when you take someone from ugly teeth to composite veneers, and they may not be awesome, you take them from ugly to pretty decent, it's like, whoa, that's awesome. When you take people from ugly teeth to temporaries, now all their appreciation is super heightened. And they're like, yeah, but what about this line angle? You see right over on this corner, right? Everyone does that with porcelain because you've just raised their intellect. You've raised their dental IQ. And now they're looking at all these ridiculous little things that they don't do that with composite. I mean, they will a little bit. I mean, I got some pretty picky people, but for the most part, I can get away with a lot more stuff in composite than I can in porcelain. And it's just easier. It's just easier once you learn the skills. Once you learn the skills for sure. So I'm a big fan. I love composite dentistry. I love controlling it. I love so many things about it, but mostly it's just control. And there's people say, oh, you're such an artist. And I can barely draw a stick figure. I swear to you, but I've learned line angles. I've learned shape and contours of teeth. And I love being able to do that. So, and it's fun in the practice and it's super, super profitable when you set your fees accordingly. And my friend Corky Wilhite said, we were talking about veneers, and he told the class, he said, you know, you all know Corky? He's from New Orleans, so he's got his little, you know, I think y'all ought to be paying more because I'm taking away less of your tooth. So I think composite veneers should cost more than porcelain veneers. And I'll say that to patients. It's like, I'm charging you less and probably should be charging more because I'm taking away less of your tooth. So food for thought. Kirk, I don't know if you know how you and I first met. The very first time you and I met was at the Southwest Dental Conference back in probably like 2016 or 17. We were introduced to each other. Margus was down there and a couple other people, and we just got introduced. And that was the very first time that I met you.
And that was was that in Austin, Texas, or
Yeah.
where was it? Yeah.
No, that Dallas.
Dallas. Okay.
From
Yeah,
the
I
Southwest.
don't remember that. I remember running into you all the times after that. Yeah.
But mostly, Kirk is just a dear friend, and I'm grateful. This is my team. Kirk presented to study club that I belong to in Chicago not too long ago. This is many of my team members. Great presentation, as always. Some disclosures, just so you know where I'm coming from. I do adjust my photographs. So if one photo, if I'm showing a before and after and one is darker, I'll lighten it so that they look better, more even. If you can't really see something, then I want to lighten it so you can see it better or darken it. I'll crop it, I'll rotate it, I'll do all that stuff. So the histogram is getting the lightness corrected. I'm a consultant for Brasseler, Clinician Choice and Cosmonet. And a founder, I'm owner of a company called Dental Online Training. Dental Online Training is where we do workshops from the comfort of your own, in my case, the basement, where I teach the courses, but you can do it in your office, you can do it in your home, and we send you kits. And this morning, before this, we had what we call our coffee and donuts. One Friday morning a month, we do a mentorship session. People bring in their cases that they're working on, and here's their pearl. They take floss, they take AccuFilm, and they rub AccuFilm over the floss. They hold the crown in place and then they floss through the contact. And then you get an articulating mark on the contact point where it's too tight. So you take off your crown, you can adjust it, and you keep doing that. I never knew about this. Apparently, this is like knowledge that's out there. It was brand new to me, so I'll be implementing that in my practice on Monday. So those are the type of pros that we do. We have these guides that we have, but mostly we're about these workshops, and we do in person, live, virtual, where there are 1 or 2 day workshops where we do everything from composite veneers to porcelain veneers to whatever. Here's what I know. I need to do it to learn it. And Confucius said, I hear, I forget. I see, I remember. I do, and I understand. And I think for dentists, it's like, I do and I learn. Because it's one thing to hear it and see it. It's another thing to actually get in it and do it. And so that's sort of the basis of dental online training. That's Confucius. This is what it looks like. These are type of the kits that we get. If anyone's interested, there's a little QR code. All right. Also, I love rubber dams. You are not going to see any. I don't think I have any cases in here where I use rubber dams, but I love rubber dams. So if you're a rubber dam person, you'll see the cases I show you. I'm not using a rubber dam because I don't use them for everything, but I do love using rubber dams. Just don't be hateful if you see cases not using rubber dam and you think all cases have to be done rubber dams. Confucius was not a dentist. Let me just say that. Confucius was not a dentist. Because he said, life is really simple, but we insist on making it complicated. Dentistry is complicated, man. Dentistry is complicated. Our patients are complicated. Our teams are complicated. Bonding in a crown is complicated. What I hope to do today is take a complicated subject matter like a missing lateral incisor and simplify it and be able to break it down into some basic thought decisions as you're working with your patients. So when we're looking at congenitally missing lateral incisors, a case like this, or a case like this where the canines are in the position of the lateral incisors, we essentially, as treatment planners, we have 2 decisions to make. Do you want to create space for the missing lateral incisor, or do you want to move the canine into the lateral position? Option 1 and option 2. Would you all agree? We could do option 1. We could restore that with, say, a dental implant. We could do a zirconia bonded bridge or resin bonded bridge, or what I call a direct resin bonded bridge or a rib-on bridge, where we can use something like rib-on to create a structure to be able to bond to and create a tooth. We'll go over that in a second. Versus pushing the canine into the lateral position and then recreate a lateral incisor form. So I'm curious, if you all could, just in your little chat function, if you could treatment plan and both options are available, and you got a kid who's say 9 years old, you see you're congenitally missing a lateral or 2 laterals, and you get to direct it. You get to say, okay, folks, orthodontists, where do we want to go? Let's condense the space, or let's open up the space for a missing tooth replacement. So if you could, in the chat, put RR if you would want to restorative replace it, or CS if you want a canine substitute, just generally speaking. Because I have my bias and I'm curious what other biases are before I jump in any further. And Angela, could you sort of give me a Uh, um,
Yeah, it's mostly
okay.
RR so far.
Yeah, right. It's interesting in the States, we are very much restorative replacement for a lateral incisor. You go over to Europe and it's completely flipped. It's almost
Mm.
all canine substitution in Europe. And it's just interesting. A lot of it has to do with medical payment and sort of the subsidized care, I think, that goes in along with that. All right. Very basically, we call missing teeth agenesis, hypodontia. If you want to sound really, really smart tomorrow night or tonight, say, oh, we are talking about oligodontia. And then you can really get people impressed. But essentially, they all mean the same thing. We're missing some teeth. It could be just a couple lower anteriors. It could be like Ben here, who's just missing a crap load of teeth. Or one of the more interesting cases we're working on right now, congenitally missing the canines and the maxillolateral incisors, which we don't see a whole lot. We're actually orthodontically moving the bicuspids into the canine positions as we speak. But let's talk about really quickly, how common is this? Is it something that we really have to worry about? So this is from Khalaf and his group. Overall prevalence of hypodontia was 6.5%. A lot in Africa, over 13% in Africa, and we'll see that. And I think that's one of the great things about the US as like a melting pot. We're going to see people from all over the world, right? And so we're going to see this influence that we're going to have patients from, Africa. That's going to be more than what we might see from Scandinavian countries. The most commonly affected teeth were the mandibular second premolars, we remember from school, and our maxillolateral incisors. Pretty similar in their numbers, very close. This was an interesting paper. It was in the Journal of Aesthetic Restorative Dentistry. I don't know how to say it. Vaconia, I think is how you say her name. She looked at, she and her team looked at 4 decades from, I think it was 2006, I'm sorry, 1960s, 70s, 80s, and 90s. Or one decade later, they looked at 4 decades and they said, is the amount of hypodontia, is it changing over the decades? And what they found was it's not changing at all. And the most commonly missing teeth, of course, were the second premolars and the maxillolateral incisor. So it's not changing. It's been like this for 50 years or more. Majority of people are missing just one tooth or two teeth. That's what we commonly see, but we certainly have many patients that have lots of missing teeth. Today, I want to concentrate on the congenitally missing lateral incisor just because we don't have time to talk about all of them. And here's our situation, right? It could be a peg lateral and a congenitally missing lateral incisor. I will tell you, 100% of the time, if not 99.999% of the time, if you're congenitally missing a lateral incisor, the other lateral incisor, if it's not missing, is going to be smaller than normal. Just count on it. This is important when you're working with your orthodontist. We're going to talk more about tooth size discrepancy in a few minutes. But it is 100% of the time, if you're missing a lateral, you're going to have a peg lateral or a missing lateral on the other side. They're never normal sized laterals, never ever. Congenitally missing bilaterally, we're going to talk about is it better if we're doing canine substitution or worse? And this is commonly how they come into my practice. I don't know about you. I don't often get things so set up where it's one way or the other. A lot of times they're coming in, it's like, okay, what do we do now? It's like, well, the teeth are sort of in canine substitution. What's it going to take to get to open up the spaces? And that's where I think the sort of the treatment planning and thinking through things is so important. Again, with the idea that we could do a dental implant, we could do bonded bridge, resin-bonded bridge direct, or do our canine substitution. I only want to talk about fixed options. In the community that I'm in, it would not be reasonable for me to expect my teenagers to go with a flipper for however many years in the community that I practice in. So we're looking at fixed, non-removable options. Obviously, flippers are an option, and they're not a bad option depending on the community that you practice in. I want to talk about one more possible opportunity, and it's called tooth autotransplantation. And I bring this up because I'm working on a case right now that I want to share with you. So tooth autotransplantation means taking a tooth from one site and implanting it into a different side of the mouth. We'll see this commonly with third molars being transplanted into first molar sites. But the question that came to me was, and we'll also see it, and we've seen, if you've seen Greg Kinzer present, Greg Kinzer shows some beautiful cases where there's been an avulsed central incisor and a lower bicuspid has been implanted into the central incisor position. And then using direct resin, he's created a central incisor form. Absolutely just beautiful, marvelous work that he does. So I'm going to share with you, and the success rate on this is they say 80% or so, but in speaking to a surgeon who I'm going to introduce in a second, he said that the success rate is actually much higher in his practice. So let me introduce you to Ellie. Ellie's 13 years old. She's dentally delayed, which is a benefit for us, as I'll share with you in just a minute. So Ellie comes in, she's referred from her orthodontist. And let me show you what Ellie has going on. So Tony, if you apologize, I'm using the American nomenclature here, but essentially she has her upper right central incisor and her upper right first molar. She does not have any teeth in between there. No permanent teeth, only primary teeth. And we look on the contralateral side, you'll see she does have her permanent canine on the left side and the permanent second bicuspid. So let's take a look. This is what her panoramic x-ray looks like. You can see she does not have any teeth between number 8 and number 3. She's 13 years old. So let that sink in for a second. The roots on all those teeth are really crappy. Like sometimes you have people or kids who come in and they have some congenitally missing permanent teeth, but the roots on the primary teeth are pretty darn good. In fact, I just restored 2 lower incisors on a young girl who's missing 24 and 25, 3141. And I restored the primary centrals because they had really nice roots. But what do you do on a kid like this? And you think about her at 13, think about her at 16, think her at about 20. What are you going to do? How are you going to manage that? So here's the good news. So Ellie has this lower bicuspid that is not erupted. And she's dentally delayed. So we would expect by 13 that that tooth would have erupted into place. Now, for tooth autotransplantation, the root cannot be fully developed. It's got to be about 80 to 90% developed. We got lucky. She came in for the consult. We took the Panorex. I'm like, this is a blessed day. But you're on a time limit. Because what we want to do is we want to remove the tooth from the lower left, take out a couple of teeth on the upper right, and we're going to put that up there. We're going to do truly a canine substitution. We're going to substitute the canine, but the lower bicuspid. Well, when I say we, not me. Let's be clear about this, the surgeon. So that's the plan. I sent her to a surgeon in Tacoma, Washington, Jim Janowiecki. He's amazing. He took over a practice, Dave Matthews, not the band member, but the guy who worked with a periodontist with Frank Spear. And Jim is the U.S. expert on tooth autotransplantation. So this is right before Thanksgiving, a couple days before Thanksgiving. They fly out to Washington. He removes the primary canine and premolar, first molar, take those out. Removes the lower premolar in the way on the bottom, takes out the bicuspid, and this is, you can see this is the bud of the tooth, or the coronal portion of the tooth. As it gets implanted, essentially he treats it like an implant. He's going to make an implant site, put the root into there, and then it gets stitched up. And that's what she looks immediate post-surgery. She travels back to Chicago, and this is what she looks like 1 week later. Everything's healing nicely, keeping it clean, things look great. Comes back 4 weeks later. You can see the tooth crown, the coronal portion is starting to pop through now. Pretty cool. And this is the periapical. You'll notice the tooth is sideways. And I'm like, Jim, why are you putting in the tooth sideways? Because it would be much easier for me to restore it if it's like normal positioned, to be able to make it look like a canine. So here's the secret. Here she is at 10 weeks. You see that it's erupting through. Here's the root form as the tooth is erupting. So it's great so the root is going to continue to close. The root's going to continue to grow. The tooth is going to literally erupt as if it was a normally positioned tooth. And at 13 weeks, this is what she looks like. So 13 weeks, you can see she's starting to get an occlusal contact, just starting. So we got to deal with that. But now it's time to start moving the tooth. So she's going to go over to the orthodontist. I numb her up. I do some electrosurgery or laser to remove the soft tissue so the orthodontist can put a bracket on there. And I literally just put these images in about 45 minutes ago. I got them from the orthodontist. And what the orthodontist needs to do is she needs to turn the tooth very slowly. And what that's going to do is going to help the tooth from becoming ankylosed. So that's why Jenna Fikowski put the tooth in sideways so that we can rotate the tooth to prevent ankylosis of the tooth. So she's turning it, and you might be able to see there's some buttons on the molars to open up her bite so that she does not have an occlusal interference on the opposing tooth. So this was just last week, and that's where Ellie is right now. And we're getting that to set up for the canine position. So the question, and I sat down with Jim recently, and I said, so Jim, could we consider this as an opportunity for a lateral incisor replacement? So one of the first things I got to think about, if I want to put this bicuspid into the lateral incisor, is the tooth form going to work out okay? When I look at what's normal, and we'll talk about this more in a few minutes, the maxillary lateral incisor average mesial distal width is about 6.5 millimeters. The mandibular bicuspid is about 7.5 millimeters. Now that's only a millimeter difference, and actually you're going to see 7.5 come up when we talk about maxillary canines. So if we can have a maxillary canine at 7.5 millimeters, and we can change that to look like a lateral, then certainly we could do that for a mandibular bicuspid. But here's the real issue. The real issue is about the timing. When this tooth is appropriate to be able to be transplanted, not Ellie's case, obviously, case I showed earlier, but this is a situation that we're in, is that do we actually have space to place an implant in a normal situation? Like by the time the space is opened up to be able to put in the auto-transplanted tooth, the kid's going to be too old, and this lower bicuspid will have already had full root form and been erupted. So it's not so much about the size of the tooth, it's more about the timing. And it's unlikely that the timing would all work out, that you'd have enough space for them to do the surgery to be able to place the implant, and B, they have enough bone there to be able to place the auto-transplanted tooth, and have a root that's in the right growth period to be able to auto-transplant it. So while I was considering this as maybe an option, as we sat and talked about it, I don't know that auto-transplantation would work in a case like that. But I wanted to share this because I want you to keep this in mind. Jim is the only person that I know of that's doing this in the States at this type of level. There are other surgeons that are doing it, but in an aesthetic zone, this is the guy that I would turn to. There's lots of people in Europe, not a lot. There's several people doing it in Europe and Scandinavia, but Jim's our guy in the States. All right, let's talk about dental implants. This is a lateral incisor, beautiful porcelain work done by my lab technician. I just had not to screw up the impression or the position of the restoration. Now, this is what I would tell patients. Here's the advantage of a dental implant if you're missing a tooth. I don't have to touch your other teeth. It's a single tooth problem. Let's keep it as a single tooth solution. Much easier for hygiene. You just floss like normal, treat it like a normal tooth. But the disadvantages is the age, right? We have to wait till the kid is old enough to be able to place a dental implant. Also, there's surgeries involved, great deal of cost. You know, think about this. If you're congenitally missing lateral incisors, what's it cost in your community to do the bone grafting, gum grafting, implant placement, customized abutment, and a crown? 10 grand, right? 8, 10 grand, somewhere in there. Say it's bilateral, say 20 grand. In my community, people don't just have one kid, they have multiple kids. And if you have one kid with congenitally missing laterals, you probably got another kid with congenitally missing laterals. So now you got 20 grand, let's say times 2. Now you got 40 grand you got to dump into your kid's mouth after doing the ortho, right? This is also the time period where they're going to be going to school soon. They're going off to college. In the States, not inexpensive to go to college. So financially, this can be a real burden on families if we're looking at just the financial cost, let alone the other costs like surgical and all that type of stuff. So another quiz for you. This is sort of what I've been taught. Females, when they're done, facial done growing, say around 18, 17, 18 years old. For boys, typically a little bit older, 22 up to 25, 26 years old. I'm curious, is that what people have learned? And if that is, and that's sort of what the rules are that you live by, and that's what I was taught, yes or no? And if people could answer that while I take a sip of coffee, I'll wait. Water and coffee.
So far, people are in agreement with you.
Right? So here's Zoe. She was 17 years old when we started doing her implant work. Congenitally missing, bilaterally missing lateral incisors. This is the surgical software we were using at the time. Not a great match on the crowns. Did some bonding on the centrals. Not awesome, but Zoe's happy. There's the implant restored lateral incisor on the one side. Same thing on the other side. And Zoe was in about a year ago, took photographs. And if we look at almost 7.5 years later, I'm going to draw an imaginary line from the tip of the cuspid. And obviously the angles are not perfect, but they're fairly close. And I look at the free gingival margin of the lateral incisors, look at the incisal lead position of the implant restored lateral incisors compared to the natural dentition. It looks pretty close. I mean, it doesn't seem like there's much change at all. This seems to be very, very stable, right? Awesome. But there is a potential for continued facial growth with all patients beyond maturity, which I was unaware of for a very long time. This is it's a book it's an awesome book. In this book, there's so much information, but Dafferty and his group with Bahat, if you know him, he's a surgeon, he's incredible. And they looked at craniofacial growth in adults and its implication for implant reconstruction. So this is chapter 26. This is almost 10 years ago, 2016, and this is when I first started hearing about this. And they said there's long-term observations that there can be complications when that teeth and implants, there may be differences as the person's skeleton grows. Unlike teeth and edentulous spaces in the alveolus, the implant is out of sync with the craniofacial movement, staying relatively stable as the adjacent landscape slowly shifts, meaning the teeth are going to move, but the dental implants will not. Thus, when overall facial growth occurs, the implant and restoration do not move to accommodate the changes, meaning as the face grows and the teeth grow with the face, the implants are ankylosed and they don't move. All right, so this was 2016. And I thought when I started hearing this information, I'm like, not happening to my patients. I feel bad for those poor suckers this is happening to. What I did not realize that this research, or these observations, I should say, have been going on since 2004, which I was completely unaware of. And this Bernard's group, and long-term vertical changes of the anterior maxillary teeth adjacent to single implants in young and mature adults. And this is where I want to pull our attention on, is the mature adult part. So this mature group were patients 40 to 55 years old. No way should these people be having facial structure changes. They're mature, they're done growing. Through the whole group, between the juveniles and the matures, they had 16 central incisors, 12 lateral incisors, and 12 canines that they were replacing. Here's the important part. All of the mature adult patients showed a vertical difference between the adjacent teeth and the implant-supported crown measured after a year or shortly after a year. And that can be anywhere from hardly not even recognizable, a tenth of a millimeter, but almost 2 millimeters of difference. No difference in gender. Let me introduce you to Sydney. Sydney, we placed implants in her, did graft-in placed implants in 2019 when she was 19 years old. So beyond the marker that we would typically use. We're going to do some veneers. She has smaller teeth. We're doing some veneers on the cuspids and the central incisors. These are analog impression for our implants. This is the case as it's cemented, veneers on all the teeth with the implant on the lateral incisors. Looks great. I was very proud of this case. I thought this looked really wonderful. Super lovely young woman. Family is awesome. She lives in Colorado. She comes back to visit mom and dad over Thanksgiving break in November of 23, so 4 years later. Hey, Sydney, how you doing? She's in the hygiene room. I come in and say hi, doing my exam. I'm looking and I'm saying, I do not remember those gingival margins being in those positions. I thought they were all lined up nicely when I saw her when I did the reconstruction. So I said, Sydney, let me take a few photographs. I want to see something before you take off. Didn't tell her what I was alarmed about. I just took some photos before she left. This is what she's looking like. So we look at 2019 to 2023. I'm going to draw a vertical line from the cervical margins of the central to the canines and looking at the position of the lateral incisors. You can see on the right lateral, it's down about 1 millimeter, maybe 1.5 millimeters, and the left lateral, it's about at that line. When we look 4 years later, there's definite changes at that cervical margin. So I presented this recently to a study club, and an oral surgeon said, well, maybe that's just soft tissue changes, and you're just looking at changes in the soft tissue appearance. So I said, maybe you're right. So I sat down, I drew a curved line that goes from the tip of the cuspid over the centrals and drew the same line there. Now, obviously, these images may not be taken at exact the same position, but I think we can all agree that the incisal edge position has changed as well. But this is not just that there's changes at the gingival soft tissue. So I'm alerting you all that for our young adults and for my mature adults, there is potential for long-term with facial growth and implant not growing with the face. Let me introduce you to Sister Fields, a nun. You never want to screw up on a nun. So Sister comes in because Buddy, when he was practicing, we had done an implant restored lateral incisor for congenitally missing lateral number 10. She calls, she says, Dr. Hartlieb, I chipped my my tooth. Buddy had done bonding over top. I had done like a crown with a cut back for Buddy to do a composite veneer. And she called and said, hey, I think I chipped my veneer or my bonding. She comes in. She didn't chip the veneer, she's just had very slow facial growth, and you can see the step between the incisal edge and the central incisors. I gotta get the photos from Buddy from when we first did this. There's no way this gingival margin was in that position. There's no way. I gotta get the photos from Buddy. I have patients that I've placed not me, our team has placed implants in their 60s, and within years, we're seeing changes at the incisal edge and at the gingival margin. There is facial growth happening on some of our patients throughout their lifetime. The challenge is we don't know who. There's been some suggestions that it's based on biotype. If you have thin tissue, longer face, you're more likely to have it than someone who has thicker tissue. And that would certainly support that compared to Zoe, who has very thick tissue. She's sort of a thick person, versus Sydney, who's got thin tissue, skinny person. And we see that. But the research that I have seen does not support that. So right now, I tell my patients, I don't know if you're going to have continued facial growth. And here is our problem as what we've just discussed. So I am currently not treatment planning single tooth implants for any of my patients in the aesthetic zone. And just so that we're aware, in the posteriors, There's a 50% chance on posterior implants you're going to have to get an open proximal contact. We've all seen that. It's 50%. What happens when they get that open contact? They get food impaction, they get decay on the neighboring tooth. We've all seen it. So while I love dental implants and dental implants have changed dentistry, they're not without complications. So keep that in mind as you're starting to think about dental implant replacement for that congenitally missing lateral incisor. I'm not going to spend a lot of time on indirect resin-bonded bridges, but this is my go-to. You can do it with either zirconia, which is my preference, or lithium disilicate, i.e. Emax. The difference with zirconia is I can use a much smaller connector. That is the portion that goes between the wing and the pontic can be much smaller with zirconia than if you're doing it with lithium disilicate. For zirconia, you need only a 6 millimeter squared connector, meaning it can be 3 millimeters tall, 2 millimeters buccolingual. Not difficult for us to do in the anterior aesthetic zone. Lithium disilicate, you need 16 millimeters. That's 4 by 4. 4 millimeters tall, 4 millimeters buccolingual. If you'll notice, there's really not much facial embrasure here on the Emax restoration because I got to make the connector so thick so it doesn't break. The only cases I do lithium disilicate, 2 types, if I have an anterior open bite, and in cases where I'm going to do a transitional case. I got a case right now where through whatever reasons, we need to get a tooth in for this kid. I'm going to have to go back and do it in zirconia later on, but I'm going to do it temporarily in lithium disilicate because I can mill it in the office. I can do it for a lot cheaper than if I have my lab do it with zirconia. But mostly I'm only doing lithium disilicate if I have an anterior open bite. I like working off a central incisor because I get a longer connector. If you look on the canine, you have more open incisal embrasure, you have more open gingival embrasure. So I think it's harder to do it off a canine. There are other times when I will do it off a canine. 1 wing versus 2 wing options. I will tell you the success rate for 1 wing options is way more successful than 2 wings. 2 wing has a 33% failure in 5 years. So 1/3 of your 2 wing bridges will fail within 5 years versus 1 wing has over a 90% success over 10 years and about the same success rate at 15 years based on Matthias Kern's work out of Germany and others who've repeated that. So a 10-year success. And if they come off, I've had 2 that have come off over the years, and I don't know how many I've done. We've done a lot in our practice. They bring them in, you sandblast them, you glue them back on. If you haven't done these, the disadvantages, it is tough to glue these in without screwing it up. I have inadvertently not cemented them appropriately on a couple of occasions because it's really difficult to get these things lined up because you don't have much to grab onto. Why do 2 wings fail more than 1 wings? It's the bite pressures that we have. So if you imagine a 2-wing zirconia bridge, metal Maryland bridge, whatever, the bite forces for central incisors are moving the central incisor facially while the canine's being pushed laterally. So these forces over time will get this wiggling effect on the canine. Typically, though it can happen on the central, most often I see it on the canine, and then you get seepage and ultimately decay underneath. We see where this is diluted on this 2-wing bridge here, and you can see what looks like decay underneath there, and certainly there was. So I have very few occasions where I do a 2-wing bridges. Almost always I'm doing 1-wing bridges, especially for a lateral incisor replacement. Posteriors would be different. This is just for anteriors. That's sort of what they look like. This is a different case than I just showed you. This is where we have a bonding on the left lateral incisor for a peg lateral, and then we did a tooth replacement with our zirconia bonded bridge. Aesthetically, we can make them look nice. They can blend in with the natural dentition. If you're interested, I don't have time to go through everything. I have a handout. Do the QR code, it'll lead you right to it. It'll give you all the stuff from prepping, case selection, cementing, stuff like that. So if you're interested, you can grab that while I take a sip of water. Any questions on this before I continue on into moving forward? Anyone, any questions on this?
Not directly about that.
I'll take questions.
Actually, there is one. What about the rule of no distal cantilever?
Yeah, so no distal cantilever on a posterior, but I think on the anteriors you're absolutely safe. I I've done this routinely, um, basically because I wanted to have as long of a connector as I could get. Now, having said that, there are often times when I have to restore the canine because the canine is misshaped, and there may be an advantage of creating a wing that grabs onto more of the canine, but I'm going to be doing some bonding or something over top of it to hide some of the connector. So there are times when I will go off the canine, but this has been my go-to for over a decade. Matthias Kern has done the same thing. There's a lot of people who are using the central incisor as their option. You can certainly use a canine, but central incisor is my go-to because that's easier for me to get that 3 mm tall connector in height than if I'm going off a canine. But occlusally, if you got space, sometimes you just have more occlusal space on the canine, which means you'd have to do a no prep or minimal prep. That may offset that and say, you know what? Yeah, I'm going to have I got a better connector area on the central, but I don't have to prep if I go off the canine based on the occlusion. Then that may be a better option.
And there's one other question, and you can decide if it's more appropriate to answer at the end, but it says, how do you handle bonding cases that chip often? Is there a charge after so many repairs?
Yeah, we're going to do a little hands-on demonstration. So as I'm doing that, we'll talk about sort of bonding and conversations around that. Yeah, it's a great question to ask, and we'll talk about that for sure.
Cool, thanks.
Technique that I used for years and still use occasionally now, but when I was setting cases up for implants, I would do what I call the direct resin-bonded bridge, or what's commonly referred to as a rib-on bridge. And with the rib-on bridge, minimal drilling, if any, can be very aesthetic. It's repairable. And what I liked about it was easy transition to implant surgery. So when I was planning on these teenagers going to implant surgery around 17 or 18 for girls, later for boys, I could bond in these bridges. When it came time for surgery, we'd make an Essex retainer. They'd come in. I would cut off the ponic, put the ponic in the Essex retainer, have them have the surgery. A couple weeks later, I'd have them back. I would then rebond that tooth into that site. And then while they're healing for 3 to 6 months, whatever it is, they got their permanent, non-removable, not permanent, their non-removable tooth replacement while they're waiting for soft tissue grafting, bone grafting, implant placement, whatever it is. So I use this technique a lot back in the day. Now that I'm avoiding implants, not so much, but still use it occasionally. The downside of direct resin-bonded bridges is it's just a more challenging technique. You have to be good at bonding, and you have to connect both mesial and distal. You cannot do a unilateral rib-on bridge. I've tried it a couple times. I've tried it twice. I'm a slow learner, not that slow. I tried it twice. They failed super quick right afterwards. So I stopped after 2 times. It didn't work. So you have to connect both mesial and distal. So it's like a traditional bridge that way. So you can't floss easily like you can under a unilateral bridge. We can floss underneath. This is Adam. He's got some funky shaped teeth. We're going to talk about that in a little bit. This is the rib-on as it's bonded on to the palatal surfaces of the central and the canine. Using some Teflon tape to protect the tissue or support the tissue. I'm going to freehand composite, build a tooth using my direct composite techniques. You can use a putty matrix. You can do it freehand. I'm doing some binding on the centrals and on the canines, and then these are the direct resin-bonded bridges. I did these on Adam 15 years ago. He's come in for a couple of repairs. He's in Madison now. I haven't seen him in several years. He also has some lower missing bicuspids. We did the same thing on. And we've repaired him a couple times through the years, but he's maintained them for, we got to be close to 15 years now at this point. That's what I'm guessing. All right, so that's just briefly direct resin-bonded bridges and rib-on, for instance. Let's get into canine substitution because I think it's something that we have to consider. So, what is canine substitution? By definition, mesialization of the canine into the lateral incisor site with reshaping and cosmetic restoration to mimic the lateral incisor shape, contour, and color. That's half of it. So we got to move the canine and restore it. But here's the second part. You got to move the bicuspid and you have to intrude the bicuspid. Because if you think about the soft tissue position of a bicuspid, it is always coronal or incisal to the canine position. So I think one of the things that can make canine substitutions not work or not look good is that you have your central incisor, you got your canine, your lateral that was a canine, and then you have your bicuspids that are down here. And it just, the smile doesn't look right. So part of the treatment we're going to talk about is get the canines in the right position. Here's the advantages. Conservative, minimal dentistry for the patient to maintain. If, when I was in dental school, if someone lived to 80 years old, that was like, whew, you got an octogenarian in your practice. The kids we're treating today, they're going to live to 100, 110. So we got to think about their teeth for 100 years. Dentistry was easier. 50 years ago, people didn't live as long. Your dentistry didn't have to last as long. The teeth didn't have to last as long. So that's a big issue. Reduced costs can be a big issue for families, something for us to consider. Disadvantages, not every case is meant to be a canine substitution. Sometimes the canines are just too stinking big and you can't make them look like a lateral incisor. What's going on with the other teeth in the arch? Are there skeletal and dental relationship issues? For instance, a class 2 occlusion probably sets itself up best. A class 3 occlusion would not work out well for a canine substitution for the orthodontist trying to be able to even try and get into an orthodontically corrected class 1 and move, 12 teeth forward a lot. That's going to be a really difficult situation. So airway issues, is there an impact if we retract teeth to close the space versus opening up spaces, expanding the jaw size? Is that better from an airway perspective? I don't know. I don't know any of us have any of these answers yet, but it's things that we should be considering and thinking about. Now, one of the questions is, can we make it look good? And the second question is, will it function? If we put the canine in the lateral, we put a bicuspid in the canine, is that going to hold up? Is this something that we should even be doing? What's the research say? This is a study that literally blew my mind because I couldn't believe the results on this. I think it's super interesting. They did this group, Schneider and his pals, they did a group where they took 100 lay people, 100 general dentists, and I think it was like 89 orthodontists or 81 orthodontists. They couldn't find enough orthodontists. And they gave 3 sets of images. They had people with a nice retracted natural dentition, a case where they did implant restorations with bilateral, congenitally missing laterals, and they did a case where they had canine substitution on bilateral, congenitally missing lateral incisors. They asked the 100 lay people, they asked the 100 general dentists, and they asked the 81 orthodontists to rank their preference. Do you like this the best? Which one do you like second best? Which one do you like third best? And this is what they found. The orthodontists and general practitioners favored the natural dentition first, then the implant replacement, and then the canine substitution. Makes sense, right? This is what we would think would look natural. This is what blew my mind. You know what the lay people loved the most? Their favorite was canine substitution. I don't know if you've had this in your practice when you restored teeth, that people sometimes want the laterals to be wider. They want the incisal edges to be closer to the central incisors. They don't want embrasures. Y'all have this stuff from some patients? It's interesting that the lay people think that the lateral incisors should be wide and fat and longer. They apparently didn't Google that because otherwise they would know better. So aesthetically, can we get away with it? Apparently, we can. So even if you do it poorly, I think you can get away with it aesthetically. What about functionally? I think this is an interesting study. Rosa and their group, they did they did canine substitution cases, and then they looked back 4 years later. I think it was 4 years later. Oh, this is a 10-year. This one was a 10-year. They looked at four, and then this is the 10-year result. And they said, how are these canine substitution cases managing functionally with the bicuspids in the canine position compared to cases where we did not do, where they had natural dentition, natural canines? Bottom line, there was no risk for any periodontal tissue deterioration or TMD in the long term. They did not see any difference between the control group, which were natural dentition, canines in the canine position, versus a canine substitution case where the bicuspids were carrying the load of the canine. So functionally, I think we can say, yep, we can do this. We can manage that. All right, so we can do it aesthetically. We can do it functionally. What do we need to know about? What are some of the challenges? We got to understand what are the patients and the parents' expectations. You know, bottom line, when I have a kid in, and it could be Elliot who's 13, it can be, you know, someone who's 16, whatever the age, and I don't see a lot of kids, but I see them for aesthetic stuff. I ask them, what are you looking for? What do you want? And then I say to the parents, what are you looking for? What do you want? And hopefully we can match those. The biggest problem that I find when patients come in with congenitally missing lateral incisors, they don't understand that there oftentimes are more teeth involved than just the missing lateral incisors. We already looked at Adam and we saw his misshaped canines and centrals. There he is there. Those canines don't look anything like what a natural canine would look like. Do you all agree? Right? The central incisors are smaller than average. They're smaller than normal. So what we have to do, we have to know the other teeth in the arch. What you have to understand is very commonly, other maxillary teeth are smaller than normal when you have peg laterals and congenitally missing lateral incisors. There's Will, those are small. These teeth are more narrow than average. In fact, this raises an issue with orthodontists that I have. I have a different case, small central incisors, and the orthodontist has a central incisors brought together, and the tissue is super swollen between the central incisors. So it's an orthodontist I don't work with very much. I sent him a note, send him a letter, sent him an x-ray where the roots are really close together. And I said, we have a root proximity issue. Can you create a millimeter and a half diastema between the central incisors? And he said, no, I'm not doing that. These teeth need to be put together. Literally said no. And so the tissue on the other patient is really swollen because the roots are so close together. So it's common that I have to create a midline diastema because the clinical crowns are smaller than average and the roots are normal and they're just too close together. We got to give the papilla some room to breathe. This is a case I showed you earlier. So we have a peg lateral with congenitally missing lateral. Look at the central incisors. Look at the tooth form, tooth shape. Jane Wright from Marquette on her master's thesis, she looked at upper teeth related to normal when you had a congenitally missing lateral incisor. What she found in her study was Caucasian males experienced smaller than normal posterior maxillary teeth, and females showed smaller anterior maxillary teeth. The bottom line is you got to do a tooth size review. So whether it's a Bolton analysis or what I do is I just measure the teeth as I'm talking, as I'm doing my consultation. Are your teeth average in size or are they smaller than average in size? From the European Journal of Orthodontics, this is back in 2012 from Mirabella and her group. Patients who were missing maxillary lateral incisors had smaller teeth compared to control subjects, except for the maxillary right and left molars. So there are a number of studies that support, and I see it all the time. If someone's got a peg lateral or congenitally missing lateral incisor, look for other teeth to be smaller than normal, like Adam. Because if you imagine I just put a lateral incisor in there, the canines aren't right size. I got to add to the canine. The central incisors need to be rebuilt. this is common. So patients come in thinking it's a one or two tooth issue. It's one tooth on one side. Say they're missing a lateral incisor on the right side. They don't understand this is probably a six tooth issue. You got a peg lateral on the left side. You have smaller than normal canines. The central incisors often are not the same shape. This is not uncommon and something that you need to really take a look at. It's common that the central incisors are asymmetrical. You look at LOEs, look at the difference between the right central incisor and the left central incisor. They don't look anything alike. We look at the right central versus the left central. Length, width, tooth form, right central versus left central. I could show you literally, I bet 30 to 40 cases where central incisors are asymmetrical. You don't notice it because you're just worrying about replacing the missing tooth. But when you do notice it is when you're doing the prosthetics, trying to get that lateral incisor to look like the other side. And then all of a sudden you realize, well, my central incisor is a millimeter more narrow than the central incisor on the other side. How are we going to manage that? So take a look at your central incisors. Make sure that your central incisors are symmetrical. If not, talk to the patient about it. I can restore the space, but your front two teeth are different sizes. You're going to notice that. It's not going to look right. Tooth position is such an issue that when the canines come in, they're coming in too mesial. How do we want to manage that? Orthodontists need guidance. Are there any orthodontists in the group today? Everyone restorative? All right.
I don't think so.
Orthodontists, I got great orthodontists around me, but they're great when the teeth are the right size, the right shape. The problem, not all, almost all. When the teeth aren't the right shape, the right size, it becomes very difficult for them to know where to position the teeth, and they need our guidance. This is a patient that came in, they were sent over from the orthodontist, they're ready to deband, and they wanted to know if this is all set to deband. This is a big problem. The canines are huge, the central incisors are, whatever. This is a difficult case. You can't really restore the case where these teeth are. Here's a case where I have a peg lateral on the one side with a huge space for room for another peg lateral, and I got a side over on the other side where I could put in probably a central and a lateral on the other side. Orthodontists have challenges when they are trying to figure out what to do with these teeth when there's congenitally missing laterals or other teeth. So we need to help them. To help them, we need to know what's normal. So these are a couple studies that are most familiar. This is Sterrett's group from '99 and Pascal Magnier's group. What they found was between the two, let's just say this, central incisor should be about 10.5 to 11.5 millimeters long and about 8.5 to 9 millimeters wide, with a width to length proportion 80 to 85%. That's the numbers that I use when I'm looking. Okay. Stephen Chu did a great study where he looked at lateral incisors because he was working with Dennis Tarnow and said, okay, we got to do implant replacement for these congenitally missing laterals. What's the normal size of a lateral incisor? Bottom line, about 6.5 millimeters is normal for lateral incisors, plus or minus a half millimeter. So when I'm meeting them with a new patient and we're trying to figure out, hey, we're missing a lateral or we have a peg lateral, these are the numbers that are in my head. And you're welcome to take a photo of this. And I think this presentation is going to be available, right, Angela? They can go back and look at it.
Yep.
So yeah, you take photos of any of this as we go along. These are the numbers that are in my head when I'm looking, hey, how are we going to manage the spaces? What are the two sizes? What are things looking like? So what's normal? Now, as we talked about with the bicuspid, the mandibular bicuspid, look at that. The canine average width is about 7.5 millimeters wide, which is about a millimeter wider than the lateral incisor. Now that's average. Sometimes you'll see big old wide canines that can be 8.5 millimeters wide. And if you have a case like that, you got to really question, how am I going to take away 2 millimeters from the crown of a canine and be able to make it look like a lateral incisor? So that's why knowing what normal is will help you determine what you need to do. So again, as we spoke about, our canines and our central incisors should be on a similar horizontal line. The lateral incisor will either be at that position or about a millimeter coronal to there, what we call the gull wing appearance versus a straight line. And the bicuspid is also about a millimeter coronal to the gingival margin where the canine is. Sometimes it's more. The height of contour is towards the distal. The zenith is towards the distal. This is very important when we're talking about peg laterals. I'm positioning peg laterals, but also central incisors, if they're more normal than average, we're going to talk about why we need to create that space to make the central incisors look normal. As we're aware, the incisor embrasures open as we move from central incisors to the distal. They're going to get bigger and bigger. And same with the gingival embrasures. Just some basic concepts. We don't have time to go through everything. Here's the last concept that you really need to be aware of. I will tell you, not always, but almost always, these kids with peg laterals and congenitally missing laterals, they have what's called altered passive eruption. I never understood altered passive eruption until I read this article. Well, actually, this is when it was first coined with Slick Van Arsdale and Arnie Weinsgold. They spoke about the classification of tooth eruption. They had 4 categories of eruption, differentiated by where the CEJ is and where the bone is and where the soft tissue is. So what's altered passive eruption look like? In Maya, you can see where we only see maybe 50% of the canine. How much of the lateral incisor do we see? How much of the bicuspid is actually being visible? In these other cases where at, say, 16 years old, we should expect to see most of the clinical crown. And we see it quite commonly, and this back to Eloise, you can see you can't see her centrals, any number of cases. So the question you have to ask yourself, is it gingiva just too much gum tissue, or is it gum tissue and bone? And this is where I started to really understand this. This is from Bill Robbins, who's a big friend of ACT and all that stuff. And Bill wrote this great article that breaks it down. And so when I read this, it started to make more sense to me. So what is altered passive eruption? First, let's talk about normal eruption. So, and I said, I talk to patients and their parents. I say, okay, remember when, let's say Susie's in the chair. Remember when Susie was like 6, 7 years old, and I'll take my gloved hand and I have my lab coat on, and I say, remember when the tooth started just sort of peeking out like this? All right, this is normal. And what should happen is that tooth should keep coming out of the gum tissue until it gets to the root. So you got the enamel, and then the root begins, and the gum tissue should stop right where that root begins. That's normal eruption. So for us, part 1, active eruption, is when the tooth erupts. It finds a contact point on an opposing tooth. The gum tissue is still over a good portion of the clinical crown. But the bone has receded to the normal position, about 2 millimeters apical to the CEJ. That's part 1. Part 2 now is what's called passive eruption. Now the soft tissue is just going to recede back to just above the CEJ, creating that, what we know the biologic width, about 3 millimeters. That's normal eruption. Altered passive eruption is 2 forms. Type A is where the bone has gone to the normal position, but you just have an excess of gingival tissue. I will tell you, I don't see this very often. This, when it occurs, you can just use surgery. You can just use like your electrosurgery or your blade or your laser and just trim away the excess tissue because the bone's in the right place. It might look like something like this. This patient came in for a chipped tooth. We're talking about her smile aesthetics, talking about how the gum tissue should be a little higher on these teeth. She was cool for me letting do a little bit of crown lengthening. So I'm measuring without probing to the bone. I'm at 3 millimeters just with the sulcus. Maybe I'm getting slightly into the attachment. And then as I start probing in, I'm getting closer to 4 millimeters. So I feel like, okay, I can take a millimeter of soft tissue away at a 3 millimeter sulcus. Going back after I do my reshaping, I'm about 2.5, 3 millimeters. And this is how she is. So this is just where the bone's in the right place, but the soft tissue is just a little excess. So I'm going to trim that away. Again, don't see that a whole lot. This is what I typically see. Excess tissue and the bone is around the CEJ. There's no space or minimal space. In those cases, you got to do a full flap procedure, pull back the gum tissue, trim away the bone, set it about 2 millimeters from the CEJ, stitch them up, and let them heal. The case that we did in my office with my partner, Chris Ching, he did the surgery for me. We're going to flap it back. You can see the bone on the lateral incisor, the central, the canine. Let me highlight those. You can see on the right, on the left central versus the left central. So we're going to reshape the bone, create proper anatomy. So then when we finish, stitch her up, now we can start to see the full clinical crowns. So again, what is normal? Now, you will have patients come in and say, you know what? Yeah, she or he, they have short teeth. My whole family has short teeth. All right, maybe they have short teeth. The first thing that we'll take a look at is there any incisal wear? But let's say there's no incisal wear. And now we're saying, is this just a short clinical crown? How do we know if it's a short clinical crown versus a tooth that has altered passive eruption? We probe for the CEJ. Learn this from Bill Robbins. Take an Explorer, rub it up underneath the gum line, unanesthetize. This is just during your examination. I'm going to feel with my probe. And I'm feeling for the CEJ. Does it go from smooth of the enamel onto the rough of the dentin? Can I feel the little lip of the CEJ? If I can feel the CEJ as I'm probing underneath the gum tissue, you know, they just got a short clinical crown. They're right, runs in their family. More commonly, what happens with altered passive eruption, we probe underneath the gum tissue, and all I feel is enamel, super smooth. Now, we can use x-rays, we can use CBCTs also to give us some more information, but this is an easy way to check to see what's going on. Where's the CEJ? So comparing, if I can't feel the CEJ, then I'm thinking altered passive eruption. So short clinical crown, I feel the CEJ underneath the gum tissue, altered passive eruption. I have the same amount of tooth structure that's showing, but there's a lot of enamel that's underneath the gum line. Understanding what the tooth size is. All right, I want to get to the hands-on, so I'm going to run through this stuff. Canine substitution. Here's what I'm thinking. Do we have an airway issue? If we have an airway issue, is the orthodontist going to be protracting everything and making a potential airway issue worse? Some orthodontists are able to protract, bring everything forward. Not many in my community. So I'm concerned about them retracting, causing more of an airway issue. So I would likely say I don't want to do a canine substitution if I'm concerned about retraction with an airway issue patient. Is the canine bigger than 8 millimeters? I got to get it to look like a 6.5 millimeter lateral incisor. That's tough to do the wider they are, so maybe not. If the central incisor is a big, wide central incisor, maybe I can get away with a wider lateral incisor. And I say, all right, so the canine's wide, but I don't have to get to 6.5. Maybe I get to 7 millimeters on my lateral incisor. I got a wide central. That might look just fine. How are you going to manage the canine color? Not that can it be managed. How are you going to manage it? Are you going to do selective whitening? Are you going to veneer it? Remember, the canines are going to be more chromatic. So you got to manage the canine color. Is there lower incisor crowding? Should we talk about removing a lower incisor, just doing canine substitution, skeletal classification, stuff like that? Unilateral absence is more difficult. So canine substitution on one side, peg lateral on the other side. Not that it can't be done. I showed you the case that I did do it. It's just more challenging. So just be aware, you got the big root of the canine, you got a little root of a peg lateral. Those are more difficult to aesthetically make them look the same. They are easiest if you have bilateral absence of your canines. Other things to consider. Bottom line, can I make a canine look like a lateral? This is Julia. Julia comes in referred from her pediatric dentist. She has a canine already substituted in the lateral position. The parents take a look at her central incisors, by the way, while I take a sip of coffee. Are they symmetrical? I'm telling you, you're going to see it all the time. They just have different clinical crown forms. Not always, but a lot. So the parents do not want any treatment done on the other lateral incisor. I informed them about the central incisor discrepancy. They didn't want anything to do with that. They just want the canine to look like a lateral incisor with as minimal treatment as possible. So you could do it today with exocad or any sort of the softwares. This is before I was using exocad. I'm just going to outline the tooth on my keynote presentation. I'm going to flip that over, run over to the canine. This is what I'm going to have to do to make this lateral incisor look like a canine. I cautioned them there's going to be a space between the central and the lateral. They were okay with that. Looking from the occlusal view, same thing. I'm going to outline the facial form, flip it over. This is where I'm going to have to add tooth contour. This is where I'm going to have to take away tooth contour to make it look like a lateral incisor. I don't show it step by step, no time today, but you can see where I added some bonding onto the mesial. I really brought back the distal of that canine. So for before to after, shorten the canine, obviously, and then really brought in that distal aspect of it. You can see the chroma, especially in the full face view. Look at the difference of the chroma of that canine substitution versus the other lateral incisor, right? I didn't do a full veneer on it. I was trying to be as minimally invasive as possible based on the patient's desires. When you look at from the occlusal view, look at the central incisor, the contour of that versus the other central incisor. And then as we finish the lateral, and this is where I really had to scoop in that lateral, the canine to make it look like the lateral. We looked at this case. I want to fast forward so we can talk about how you set these cases up. So this to me is just like a regular case that I would see in the practice. I have the canine that's coming into the lateral. This is going to be a canine substitution, peg lateral on the other side, altered passive eruption, smaller than average canine, smaller than average central incisors. All right, this is what they look preoperatively, knowing our numbers. All right, so first thing we want to do is I want to get the aesthetic crown lengthening done. This is the most difficult conversation with the parents and the kid. It's like, we need to see all your tooth structure. They were not ready for that conversation, so just be aware when you start talking about that. We're going to raise the tissue, change the bone shape. Now the orthodontist can see where the teeth, the full size of the teeth. There are times when I'll go in and I'll do some transitional bonding right here. Maybe I'll do transitional bonding on the peg lateral, make it like a full lateral incisor, change the shape of the canine, or I may do it a little bit later. But bottom line, I got to move the canine closer, got to mesialize that. And oftentimes I want to erupt it so that the CEJ is just coronal to the central incisor. The bicuspid gets intruded and then mesialized, leaving a space so that I can make the bicuspid bigger to look like a canine. Reshaping the canine at some point so I can start setting things up. And at this juncture, I'm going to now intrude the peg lateral because the soft tissue's too coronal. So let's get that to a normal position. And then you can use whatever restorative material you want to restore this. Do you want to do this with direct bonding or you want to do it with porcelain? And that's what it would look like. Now, notice we talked about the zenith of the centrals, the laterals. Canine should be to the distal. If you don't open up a midline diastema, very often your zenith on your centrals are going to be too centralized, too much in the center of the tooth, or even maybe too much of the mesial. And while it's not horrible, it's just not great. That's why I have the orthodontist frequently open up a midline diastema so that I can create proper contour and form. This is a case where the tooth is the tissue is just way puffy. Yeah, there's a lot of plaque, there's a lot of issues, but we open up that midline using direct resin. We can go ahead and restore it and we can get nice healthy tissue. So that's what we'll do. We're going to move the centrals. and then we restore them. And then I get much better contour for the centrals, and I can get everything to blend in more seamlessly. I'm going to finish with Carly's case, and then we're going to do some hands-on stuff. Carly is the daughter of an endodontist, and this is how I see her for the first time. The orthodontist is like, Brett, we ought to work with dentists because I've done some canine substitution cases with them, and they've come out nice. So that's how Carly ends up in my practice. First thing I want you to take a look at is look at the excess tissue on her canines. We're going to get her head straight first, just for reorientate her. You can see that the central incisors are tipped like this, so we're going to need to get the central incisor straightened out. Jessica Cohen's the orthodontist in our community that I'm working with. See what I mean about the taper of the central incisors? You can see maybe 50% of the canine, maybe you see 30% of the canine on this side. How can you know where to place these teeth if you can't see the full clinical crown? For me, there's no way. Like, I have no idea where to place those bicuspids because I don't know where the CEJ is. I don't know where to land those canines because I don't know where the CEJ is going to be. Right. Now we look at these centrals, and I told Jessica, or I was writing a letter to Jessica saying, I think these teeth need to be uprighted, but we took a PA, and actually the roots are nicely aligned. It's just that the clinical crowns are tapered awkwardly. And that's just not unusual when you have canine missing laterals and when you have peg laterals. You get some funky shapes to these clinical crowns. All right. She's off to my buddy, George Mandelaris, who's here in the Chicago area. George does the aesthetic crown lengthening. This is where the bone is. The bone is right at the CEJ. Carly is 16 years old. We would expect to see the full clinical crown at her age. The canines, the bicuspids. So George is going to go in and do reshaping. Now we can see from the bone to the CEJ, we have our 2 millimeters. And look at all that beautiful enamel that's exposed. It's like awesome. And that's being very conservative. Quite honestly, we could have gone more on the canines, but just trying to be ultra, ultra conservative. All right, now it's just orthodontic time. Before we get into the ortho, a lot of times I'm going to help the orthodontist by creating proper tooth form, because I've just found it easier, less back and forth, if I can just do some transitional bonding, show them what the tooth should look like, and have them reposition the tooth. So that's what we're going to do here for Carly. So before she goes back into any ortho, I'm going to do some slight preparation, but I got to really bring in the distal. This is what the tooth preparation looks like. I gotta also manage the chroma of the canine. So I'm gonna do a full veneer on here using bonding. I have retraction cord, and I have Teflon tape that I'm using like retraction cord around to help with any bleeding. Evan-S is the composite I'm using, this clinician's choice, to create her bonding. Supporting the incisal wall first, doing some opaquing so that darkness doesn't shine through. This is Cosmonet's Creative Colors using A1 opaquer and then some white. And then using the universal or the enamel shade over the surface to create the proper color and balance for the the canine now lateral incisor, and building the bicuspid up as a canine. So as we finish, this is how the lateral looks, and the canine now the bicuspid. You can see the bicuspid is hanging down here because I want to have intrusion of that bicuspid to get it into the cervical margin up here. So it's purposely long because I know the tooth needs to be intruded. This is pretty close, maybe a little intrusion there. So you can really see it right here. This needs to be intruded and intruded. So now Carly can go through the final orthodontic tooth movements that she needs. And at some point we can go, and then we can transition her into porcelain restorations if we need. We can resurface these with a more polishable composite if we want. but essentially she's set up for success, making it much easier for the orthodontist now to be able to do the final positioning of the teeth. All right. If you're interested in dental online training, again, there's our little thing. We do have a 2-day workshop coming up on porcelain veneers in just a couple months. You'll get a model. It's a 2-day workshop. We go everything from making putty matrices to we get the burr blocks. I show the burrs that I use step by step by step, when to open contacts, when don't you open contacts, all that type of stuff. So we go through all that in our next virtual workshop if anyone is interested. And actually, if you sign up and you become a DOT member, we send you the kit for free, which is a nice little savings if anyone's interested. All right. This is my Angela. Angela and I own this boat here. This is our sailboat. It's called Carcane, which is a mythical sea creature written about in a book on Lake Erie. This boat is more migraine than Carcane because we've had all sorts of motor problems with it. But she's beautiful to look at and to sit on, except when the motor breaks. That is the presentation.
Awesome.
Now, let's do hands-on, and we can talk while I'm getting set for the hands-on.
Sounds good. Dr. Shin, did you want to ask any more questions to follow up? I put him on the spot. No, he's good.
Question about composite chipping. Here's the beauty of informing patients of what their options are. So let's say someone comes in with a class 4 fractured tooth. They got a chip on a tooth. I tell them you have 2 options. I can do it in composite or bonding material. This is what the technique is like. Blah, blah, blah. Minimal drilling, da, 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 da. Option number 2, I could veneer the tooth. This is what it would look like. And I go through all the stuff, especially on a single tooth, trying to match a single tooth, and it's going to take multiple try-ins. I give them the option right in the beginning. These are your 2 options. Patient comes back. We've done bonding. They've chipped the bonding. All right. So it depends on. So we have, in fact, Angela, I can supply we have a before your appointment and an after your appointment sheet for patients. So before your appointment is no whitening of your teeth for 2 weeks prior to your bonding because it affects our glue. So no whitening toothpaste, no whitening mouth rinses, no home whitening products. Wear something warm because we keep our office cold. Bring headphones, all these type of things. Post-op, we say, here's what you can't do. You can't use your teeth as tools. You cannot use your teeth to open things. You can't use your teeth to open packages. You can't use your teeth you have scissors to open packages. Don't use your teeth to bite your cuticles or your nails. You have nail trimmers for that. If you bite your nails on bonding, you will break your bonding. 100% you will break your bonding. Can't use your teeth to tear things open. Can't use your teeth to open water bottles. Can't use your teeth to tear off price tags. Can't use your teeth, blah, blah, blah. Can't use your teeth as tools. Secondly, if you grind your teeth, you need a protective appliance. You've worn down your natural teeth, the hardest substance in the human body, harder than your bones. If you do not have protective appliance and if you don't wear it, you will likely chip your teeth. You will chip your bonding, you will wear down your teeth. All right, that's all signed. You understand that. Patient comes in, chipped your bonding. How'd you chip your bonding? I don't know. I woke up, it was chipped. Were you wearing your night guard? Nope, not wearing my night guard. Or they are, it's like, well, how did you chip your tooth at night if you're wearing your night guard, right? What I have found is Essex appliances on heavy grinders. I've had multiple patients that have come in with bonding and an Essex because they don't want a full night guard, and they've literally woken up with the bonding inside the Essex, that they've ground so hard that they've chip the bonding inside the Essex appliance. The bonding is inside the Essex. Those are patients that it's not a difficult conversation saying, I think you need a stronger appliance. So if it's a recent bonding, I say, look, I might have missed something. Maybe I missed your bite. Maybe as you're grinding out, maybe I didn't manage that well. Let's redo it. Let me spend more time making sure that the bonding's right. Make sure you're wearing your night guard, blah, blah, blah. Don't use your hands. Don't use your teeth as tools. All that stuff. At some point, patients got to take responsibility. And this is where I'll come back and they say, like it's chipped twice. You did it 5 years ago, it's chipped twice. Great. Let's go to the other option. The other option is porcelain. So again, here's how porcelain works. We grind down your tooth. We take an impression, send it to the lab. The veneer will be back in 4 to 6 weeks. We'll try it on. It's not going to look right. I'm going to take photos. I'm going to send it back to the lab. I get through halfway through that and they say, you know what? Actually, that's fine. Let's just do the bonding. I'll be more careful. But start out talking about porcelain as an option. Remind them that that is still an option. I'm happy to do porcelain. Porcelain can still chip. If porcelain chips, I got to cut it off and redo it. I can't repair it. But I always bring them back to porcelain as an option because it's an option. And it can be the right option for the patient, but bring them back to that. So that's how I handle in the practice. The first time it chips, you know what? Maybe I missed something. Let me take a look at that. But here's what we talked about. You can't use your teeth as tools. Da, 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 da. We can always do it in porcelain. So I hope that answers the question, but that's literally the conversation I have with patients.
I love that.
Have them own it. That's the main thing. Have them own it. All right. Here is our patient we were just looking at. This is after her aesthetic crown lengthening. Let me focus that a little bit. There we go. And this is what we want it to look like. So how do we do that? We're going to do this very quickly in just about 15 minutes. So let me walk you through what I'm thinking about as I'm prepping the tooth and as I'm doing my bonding and stuff. From a diagnostic wax up, I created two models. I created two matrices. The first one is going to be my palatal incisal guide matrix. I don't use these a lot, but I use them sometimes in practice. I just did a central incisor yesterday at class 4, and I use this because the rotation of the tooth, position of the tooth is going to be much easier. So I have a putty matrix that we'll use for placing our composite. And then I have a reduction guide, which looks something like this. And the reduction guide, this is great for porcelain veneers. This is what we talk about in our porcelain veneer course. I have these little windows I can pull back. And I can look as I prep the teeth to see, do I have enough space for my bonding? So this is based on the wax up, and I'll show you as we use it on the prep model. All right. If I go off the screen, please someone just give a holler. Okay. All right. So when I'm doing my canine, I have to reduce the incisal edge. I forgot one thing. I need my loops because I'm old. So give me 1 second. Let me call it some loops. This is one of the most difficult things with documenting cases. I don't have an extra staff person to document. So while we're working, I have to stop. I have to pull down my loops. I have to put on my cheaters, take my photo, take off my cheaters, put the camera down, take off my cheaters, put my loops on. And if we do step by step, like I most frequently document, my older vision is causing me strife. All right, so I'm going to reduce the incisal edge. Looking from the occlusal, this is the most important view, is looking from the incisal. This is how you know if you have enough reduction. When you're doing your bonding, this is how you look for your line angles. So I can see in the center of my tooth, and I should have a pencil here, but I don't know where it is. So I'll just point. This is really where we have to do our reduction, is in this zone in here, and then I have to bring it in onto the distal. So it'll look something like this. And I've also drank a lot of coffee this morning. I'm pretty careful with my coffee consumption when I'm treating patients. So if my hands are shaking, they're highly caffeinated right now. I was up late watching the Michigan basketball game, and so I'm going to blame my team not putting them away early like they should have. And then I'm going to really tuck it in on the distal and even open up that distal contact. So you got to be relatively aggressive to make room for the restored material, but less than if you're doing porcelain. When I check with my putty matrix guide for the palatal wall, one of my problems, did I leave the bicuspid? I did. Okay. I think I've shortened the cusp on the bicuspid, but I'm looking first of all for the incisal, and I say, okay, it looks like I got enough incisal space. So then I go to my reduction guide, and I pull back the first swinging door. Let me get these so they're adapted. And I can see, you know what, I'm in the mid facial of the lateral. I need some more space. And then towards the distal, maybe a little bit more too. So I can go back. And in the mouth, I would draw with a pencil where I wanted to reduce more on the tooth. Really driving in this distal. I would use a diamond disc, which I don't have here. I didn't think about having one of those with me. But let's see if I do this with. I'm going to use a coarse composite disc and see if I can open that contact a little bit. All right, so I'm just going to use a coarse disc where I would use a diamond disc in the mouth. And I would open up the contact. To get to a shape like that. But I would use a diamond disc in the mouth. All right. And I go back to my window guide. And I check and say, let me pull back the first window. How's my space looking? I want about a 0.5 millimeter to 0.7 of a millimeter space, and I'm looking pretty good. Smooth off along the distal incisal. Pull back that second window, and I'll go to the cervical area of the tooth. And again, towards the distal, I need a little bit more room, but generally speaking, it looks like it's pretty close. So to do the bonding technique, in the mouth, I would protect the neighboring teeth. I would etch the tooth, place my adhesive. Angela, I should have done this like the cooking show where I have it already set, pull it out of the oven, done.
This is more fun.
Right.
Is this what your classes are virtually?
Yeah, but except everyone has the same model that I'm working on.
Okay.
Step by step. So we're going to make a putty matrix together. All right, everyone has their putty. We send you the putty. It's in little containers. All right, this I'm going to make my putty. I'm going to show you how I'm going to do it. All right, now you all sit down and now you guys do it. And then you can just hold up, we'll spotlight yours. You can show us yours. You can take photos. And then everyone sort of shares, hey, this is what mine looks like, blah, blah, blah. All right, this is the burr I'm going to use. You have either this burr in your kit, pull out this burr. This is how I want you to do this. Everyone get to that. All right, show me photos, hold up your thing. Let me see what you're doing. And so we just do it like step by step all the way through for 2 days. It's a great 2 days. People are like, everyone's exhausted. Everyone's like, I'm tapped out. I've worked so hard. And it's about 50% didactic, 50% hands-on for our courses. I
Okay.
try to do as much hands-on as I can, but there's stuff we do have to talk about in case we have to look at. All right. If you use these putty matrices, here's a little tip for you. I'll scribe a line. I'll take a sharp instrument and I'll scribe a line where the putty matrix meets the edge of the tooth. Place some adhesive, same adhesive that I just used. Place that into the putty matrix. I'll take some composite. We're just going to use one shade of composite. I use alcohol gauze to clean my instrument and to clean my fingers. This is the same composite that we used on the case. This is again from Clinician's Choice, their Evanesce. I'm going to roll up a little piece of composite. I'm going to place part of this composite into the putty matrix, into that line that I just scribed. That would be over here. Use my finger, I'm going to push it in. The instruments I'm using are from Cosmodent. If you're looking for great composite instruments, I will tell you, I think they are the best. This is the multi-use instrument that I'm using right here. Let me focus that. And I'm just blending this onto the putty matrix. I'm going to take another little piece now, put it onto the tooth, right onto the incisal edge. Then when I bring my putty matrix to the tooth, I'm less worried about there being a void or the material not grabbing onto the tooth well. Then I'm just blending them together. I don't use any wetting agent on my instrument. Literally, all I use is a clean alcohol gauze to clean my instrument. The alcohol gauze should be lightly dampened. You don't want to bring alcohol to the composite. You just want to keep your instrument clean. Now, the key is you have to have a nice instrument. So these titanium-coated instruments are just essential for doing nice composite work. This is called the IPC. This instrument is 1/10 of a millimeter thin. It is just ideal for working into interproximals and along the cervical margins. I literally would have such a challenge practicing without this IPC. Now, I did not get through all the way through the contact just because I was rushing through, and I don't have a diamond. It's hard to get through these plastic teeth with just a composite disc. All right, so I'm just blending it in. With the shell in place, I'll light cure. I will light cure for just a few seconds. I'm going to gently tease off my putty matrix. And you can see, actually, I would do the bicuspid at the same time. I should have shown that. I would have etched that, build this up, but you could certainly do it as two separate steps. So I spot cured that. Then I can go in from the lingual, and if I have any excess that needs to be removed, because I just spot cured, then I can easily remove it, especially I'm concerned about at the embrasures, the gingival embrasures. That's all good. So then I'll do a more substantial cure. You'll notice there's no mylar strip. There's nothing in between the teeth when I'm doing my freehand bonding. I protected the neighboring tooth with either a mylar strip or Teflon tape when I was etching and placing my adhesive. But after that, I'm not using anything in between the teeth as I build up. I'm literally going to build the tooth to the contour of the neighboring tooth. I go in with a composite saw. These are from Quick Strips. These are my favorite composite saws. Open up that contact, make sure it's not connected. Same on the distal. Do that without hitting the tissue. In the mouth, I would go now and I would do opaquing over top of this. And like in our hands-on workshops, we'd spend the time, now we're going to opaque this out. Then we would add some translucency effects. We would add some tints to give some color, to give some natural characteristics. And then we would finish with our enamel layer. We'll go back to the same composite in this case. I'm going to cut off a piece. Roll it up in a ball. If you're working with composites, my goal is to place one layer for the final material to reduce the risk of getting voids or seams between adding layer to layer. So my final enamel layer, I'm going to roll up in a ball. I'm going to get a different piece because I got all sorts of crud on that from. I'm guessing I'm going to blame Chip, my cat, for cat fur on that, but I'm not sure. Let me roll this up. Roll it into a ball. Grab it with your instrument. Bring it onto your canine lateral incisor. Clean your glove finger. Press it onto the tooth. Like so. Now, once I have this ball composite on, I'm going to start working the composite towards the cervical. I need a stiffer instrument than that IPC. In this case, I'm going to just use my multi-use. I'm going to work it towards the cervical, right in the middle of the tooth. I'm not working on the line angles or anything interproximal, just in the center of the tooth. First, work towards the cervical. Now I'm going to blend it towards the incisal. Once I have the center of the tooth essentially in position, now I can go back to my IPC. I'm going to blend this into that cervical area. It should be about a 10 to 15 degree emergence profile coming off that cervical. And now I want to start thinking about the line angles. And we get into this during the course, like, all right, line angle on the lateral incisor, where that should be. We're doing PEG lateral course coming up, actually, next Friday, Thursday, Friday. So I can tuck this in with my IPC because it's so thin. I can literally just blend it right in to that tooth structure. Come back onto the mesial. Use that IPC. Put that right in. Put it around, and then I can use this IPC now to cleave off any excess composite. It obviously takes much longer to do this when you're working on a patient. I'm just sort of rushing through this to give you a sense of creating the lateral incisor from the central, but we have to taper it back. And the key with this is you really have to bring in that distal portion. So you really have to hide this. So this is really going to get thinned out from cervical to the incisal. So we can start making it look like a lateral. I brought you right to noon as promised.
That's awesome.
Oops.
Do you feel comfortable sharing what the ballpark range is of what you might charge for something like this?
Yes, I'm trying to figure out how I stop sharing. There we go. Let's stop sharing. Where's my share button? Ah, hang on a second. There we go. So I'm not supposed to. I actually got my wrist slapped at a meeting for giving my fees. So let me say this. My fee for my composite veneer is the same as my porcelain veneer, except I add the lab costs for the porcelain veneer. So for instance, let's say my porcelain veneer fee is $2,500, for instance. I'm not saying it is. I'm not saying it isn't. It could be $3,000, could be $2,500, could be $2,000. My fee for my composite veneer is that fee minus whatever the lab fee cost would be. Because
Okay.
my time involved is about the same if I'm doing composite veneers versus porcelain veneers. Having said that, if I have a patient that I really don't want to do porcelain veneers because for whatever reason, my fee on my porcelain veneers, I increase substantially because if I'm going to do it, I know they're going to make me work way more and it's going to be more challenging. It's so much easier to block out discolorations with composite veneers than with porcelain veneers. And again, the happiness level from going from ugly teeth to decent teeth with composite is much higher than going ugly teeth, temporaries to final veneers. Those are the most challenging patients for me.
Well, it always makes sense to know what your time is worth and how long things are going to take and all of that.
Exactly. Yeah, figure out your time.
Mm-hmm.
That's how I balance it. Now, early on, my fee for composite veneers was less because I wanted to learn to do them and I wanted to encourage people to do them.
Mm-hmm.
So my composite veneers were way less in the beginning. And as my skills developed, then I started raising my composite veneer fee.
We have a really awesome, if that's something that people are interested in looking more into, a really awesome masterclass that Dr. Darren Becker did on how to set fees for, I don't even know what to call them, but I'll say like comprehensive cases, when maybe you're not doing like their traditional just one crown or something like that, that's standard, where he kind of talks about going into time and things like that. So I'll send that to you too, Dr. Shin. It's a good one. This was amazing, Dr. Hartlieb.
Oh, thanks. Thank you.
Yeah.
It's fun. It's so fun. And I love working with that age group. I love working with teenagers, adolescents. You change their world.
Mm-hmm.
You change their world like nothing I've ever experienced in dentistry. When you take a kid it's such a terrible age. It's social media and everything. Just being a teenager 40, 50 years ago was awful. It's so much more challenging now. And we can just change their lives. You change their lives. They become different people right in front of you just by making them so they don't have to be embarrassed by their smile. It's phenomenal. It's the greatest thing in the world. We are so gifted to be able to do that for our patients. And I love working with teenagers.
That's awesome. Well, good. Well, if anybody has any final questions, throw them in the chat really quick so I can let everybody out at an appropriate time. And I've already posted the CE information in the chat, so everybody can scroll up a few inches and find that. Everybody's just saying, thank you, great course.
Thank you. Hey, if anyone wants to reach out to me, Hartlieb DDS is my tagline on IG. I don't get on Instagram every day, but I'll look at it and respond. Or you can just reach me through DOT, Hartlieb DDS at dothandson.com.
Okay, awesome. And we will send the replay to folks who sign up for the BPA app by tomorrow. So if you want to pause it and see exactly what was happening, you'll have some time to access that as well. So awesome. Well, thank you again. This is amazing.
Thank you.
Yeah, truly, we can't thank you enough. I appreciate it.
My pleasure. Thank you so much. And Angela, have fun down in Kentucky.
Thank you. I will.
Safe driving. Everyone have a great weekend. And if you're a March Madness person, go Michigan.